down for a bit. So today I'm going to help you learn about epilepsy and seizures and to understand the most common types of seizures that you're likely to see as you work this next year in group homes, and to talk about the impact it can have on people. I'm using a presentation that I use in schools. So you're going to see the word students there, but this applies to all people with epilepsy. I'm also going to review with you the proper first aid, and if technology doesn't totally hate me today, I hope to show you some very brief videos. If the videos don't work for us during this presentation, I won't bore you with trying to solve it. I'll email you the links so that you can watch them on your own. And each of the videos are only 2.5 minutes long. They're very, very brief. So I encourage you, if I'm unable to show them to you today, I really encourage you to watch them on your own. We're going to talk about when seizures are a medical emergency. I know that your group homes are going to have their own protocols, but when people are diagnosed with epilepsy and or seizure disorder, seizures are the main symptom that they live with. And believe it or not, it is appropriate to just let them have their seizure, recover from their seizure, and as long as certain things don't occur, for example, they don't injure themselves in a fall, or if the seizure stops on its own in less than 5 minutes, it's fine to just keep them at home and let them recover and then go on with their day, and then just document it and report it to the family so that they can report it to the doctor. All right, so, all right, this question, if I have a seizure today, does that mean I have epilepsy? Let me unmute you. You're all unmuted. So does any of you or all of you know the answer to this question?
No.
Correct.
I believe
no
it means,
is the correct
no.
answer. Okay, so if I have a seizure today, that does not mean I have epilepsy. Seizures happen for lots of reasons, what doctors would call provoked seizures, and some of the more common examples are on this slide. I would expect most people to be somewhat familiar with maybe an infant or a toddler who spikes a high fever. They could have a febrile seizure, not epilepsy. Or perhaps an individual lives with diabetes and their blood sugar level drops too low or goes too high. That person could potentially suffer a seizure. But there's lots of reasons why people could have a seizure, and those are listed on these slides. Doctors would typically call these provoked seizures, as opposed to a person with epilepsy being a chronic neurological condition. There's something in their brain that just makes them prone to having seizures, what we would call spontaneously recurring seizures. And please notice that I am using the word epilepsy and the phrase seizure disorder interchangeably. They are the same thing. It just, some people are very, very uncomfortable with the word epilepsy. There's a stigma attached there. Now, in the United States, epilepsy is not a rare condition. There are currently 3.4 million Americans living with active epilepsy. And active epilepsy means the person has had a seizure in the past year and or they're under treatment, meaning they're either on a medication, a dietary therapy, or they have a device to treat their seizures. Sorry, I was kidding. Out of those numbers, and if you want to look at the worldwide number, for those of you that are from outside the States, the number is somewhere between 60 and 65 million people worldwide are living with the condition. So epilepsy is not rare. There are, under the epilepsy umbrella, rare forms of it. There's over 40 different conditions that come under the epilepsy umbrella. And because there are so many different ways that epilepsy can occur, that's where we get the statistic that 1 in 26 people, this is a worldwide statistic. When we look at the full population of the earth, the billions of people, 1 in 26 will develop some form of epilepsy in their lifetime. Now, referring you back to that first slide, the first aid that I teach you today is appropriate whether the person has a seizure due to epilepsy or a seizure due to some other underlying medical condition. And seizures are even more common. Worldwide, 1 in 10 people will have a seizure at some point in their life. All right. Now, when we look at who's affected by the condition, you know what? It's pretty much everybody. Anybody can develop it at any age. It crosses all races, all ethnicities, gender, doesn't matter. Doesn't matter if you're rich or poor, doesn't matter. You have a brain, you can have a seizure. You can potentially develop a seizure disorder. However, we do see when we plot the age of onset, we see the highest number of cases developing in the very young and the very old. There are certain populations that have a higher risk than the general population. And you will be spending the next year working with people who fall into this category. So looking at the general population, approximately 1.2% of the people, oh my goodness, I apologize, keep flipping it, could develop a seizure disorder. But the risk is higher for people with an intellectual disability, autism, cerebral palsy, and for older adults who are suffering Alzheimer's disease or have had a stroke. So the risk can go as high as about, for intellectual disability and autism and cerebral palsy, it can range from 10% to 33%. For stroke patients, about 22% of them will develop a seizure disorder. If you work with a client who has both an intellectual disability and cerebral palsy, their risk is 50%. Half of those people can be expected to have epilepsy as well. It is a spectrum disorder. I know we're used to thinking of autism as a spectrum disorder, but epilepsy has a spectrum of severity associated with it. So approximately half the people who develop epilepsy are put on a treatment plan, typically medication. We look at medication first to treat the seizures. They respond, their seizures are controlled, and they're on the left side of this line graph. They're uncomplicated epilepsy. There are few, if any, restrictions placed on them. They pretty much resume anything, and even adults who are at this end of the spectrum are able to drive, assuming they don't have any other coexisting conditions. But when we don't have good seizure control, people move down this spectrum of severity until they get to the end where epilepsy is truly disabling. It has a really profound impact on all aspects of their life. The seizures are not responding to treatment. Perhaps they've tried brain surgery. Maybe they're trying a device that we'll talk about a little bit later, but nothing is working. And so these frequent seizures and or coupled with the side effects from the treatments are going to have a really long-term impact on their brain. And when people have these uncontrolled recurring seizures, we can actually see physical structural changes in their brain. All right, I will briefly touch on this. So as I said, for the person diagnosed with epilepsy, most of their seizures are not going to be medical emergencies. They have their seizure, it runs its course, and depending on the type of seizure, it might be a few seconds or it might be 1 to 3 minutes. But they're not medical emergencies when they resolve on their own, come to an end naturally on their own, and that they didn't injure themselves in any sort of fall. Okay, but you have to be aware that sometimes people have forms of seizures that they don't even realize they're having the seizure, and they will not remember what happened during the seizure. I hope that you know that epilepsy is a neurological condition, so it's not contagious like a cold or a virus or a bacterial infection. It's not contagious. It's also not a mental illness, even though sometimes seizures can look really strange, have really odd ways that they present themselves. It's not mental illness. It's a neurological condition. And while people almost never die, we do know that people with epilepsy do have a higher mortality rate than the rest of the population. And we can attribute this almost pretty split down the middle between accidental death, meaning, you know, they had a seizure in a body of water and, you know, tragically drowned, or they had a seizure and fell in such a way that they cut off their own supply of air, or they had a prolonged seizure which impacted not only their breathing but their heart. But then there's also something called sudden unexplained death in epilepsy, and where you're going to be working with clients who typically might fall on the more severe end and or have other conditions where they may or may not be verbal. You want to be extra vigilant at night, because typically sudden unexplained death in epilepsy occurs when someone goes to bed and the next morning they're found unresponsive in their bed. It's kind of like sudden infant death syndrome, if you've heard of that, right? I want to reassure you that individual episodes of seizures do not cause brain damage, nor do we worry about people dying from them, because again, we know the outcome is good when the seizures resolve on their own in less than 5 minutes, okay? And then I hope the myth that people swallow their tongue during a tonic clonic seizure has died out, because it's not true. All right. And feel free to ask me a question. You can either use the raise hand icon or just call my name Susan, because we're a small group. So I don't, you know, questions during it are fine. Now, the big mystery is that, believe it or not, most of the people diagnosed with epilepsy don't know why they have it. It just showed up. Really, only 30% of the people who live with the condition can look back and say, oh, I had a brain tumor, or oh, I had an infection. So on this slide, here are the most common causes of why people would develop a seizure disorder. And head trauma is number one on the list, you know, so people who are in car accidents or sporting injuries, or our veterans coming back with head injuries from conflicts. And there's stroke again. Now, there is a lot of overlap between provoked seizures and causes of epilepsy. And the reason is, you know, let's say a person has a brain tumor and we go in and we surgically remove that brain tumor. Some people will stop having seizures. They'll be fine. The doctor will wean them off their medication. Hey, that's great. They're lucky. But if the seizures after the surgery continue to return, that is when the person would move under the epilepsy umbrella. And right now, here in our area in New England, particularly in central and western Mass, EEE, Eastern equine encephalitis and West Nile virus have been all over the news. And that would be examples of brain infections that raise the risk for people who have those infections to develop a seizure disorder. Lesser known causes of what could have someone develop epilepsy, and remember, this is only 30% of the people living with epilepsy. They could have metabolic disturbances. So I know children who have mitochondrial disease who developed epilepsy because of it. There are genetic disorders. There's actual genetic mutations in certain gene sequences, and these tend to be very, very severe childhood epilepsies. So I'm thinking of Lennox-Gastaut syndrome or Dravet syndrome. Under autoimmune disorders, somebody could have lupus, which is an autoimmune disorder, and have a heightened risk of developing a seizure disorder. And there, I did it again. I lean on the computer, sorry. And then the last few things are just perhaps birth defects, or someone was born to someone who has an addiction problem, and that raises their risk of developing epilepsy. And we can loosely group the age and causes of epilepsy. So what you're more likely to see in children are those genetic disorders, the birth defects, and or the metabolic conditions. And I don't think it should be any big surprise to us that in young adults, what we're seeing more often is the head injuries or the brain tumors as a more common cause in that age group. This is by no means definitive. Obviously, there are exceptions, but you're more likely to see. And then there we have stroke and or cardiovascular disease for the older adults. That ends my section on epilepsy. Before I move into specific seizure types and recognition, do you have any questions about that first section?
I don't think so.
Okay, moving on then. We're doing great. We'll keep it going. So what is that actual seizure itself? So the actual seizure is a brief abnormal electrical discharge in the brain that affects one of these four things: movement, sensation, awareness, or behavior. And depending on the type of seizure, it might affect 1, 2, 3, or all four of those things. Neurologists now want to classify the seizures according to where in the brain they begin and how much of the brain is involved. So even if it's only for a few seconds or for 1 to 3 minutes, if I tell you that one of your clients has a generalized seizure disorder, then you know that both hemispheres are always involved in the seizure activity, that those seizures are occurring throughout the whole brain. Whereas if I tell you someone has a focal onset seizure disorder, they're only having this abnormal electrical activity in one specific part of the brain. It could be the left temporal lobe, it could be the right frontal lobe, it could be the left occipital lobe or the right parietal lobe. You get the idea. And then they have this third catch-all category called unknown onset, because oftentimes if people are alone, seizures are not witnessed, and the person themselves doesn't know what happened exactly and can't describe it. So until the doctor collects more information, they lump them into that unknown category. So the first type we're going to review are generalized seizures. So remember, they always involve both hemispheres of the brain at the same time. All right. And so down here, what you're seeing, these leads are split. So like the top half might be the left lobe and the bottom half would be the right lobe. And as you can see, this absence seizure is affecting both the left and right hemispheres at the same time. So the types of seizures that we would see that affect the whole brain at once, and we do have some new names here. You might only be familiar with the old French names, petit mal or petite mal and grand mal. But the problem with those old-fashioned names from the 1800s is they only recognize two kinds of seizures. And as you can see from my list, there's more than that. Actually, there's almost 20 different ways seizures can present. And they completely did not understand that there was something called focal or partial seizures. But let's talk about generalized seizures first. So there are these brief staring spells called absence seizures. People can have tonic seizures where their body just goes completely rigid like a board, and then they fall over like a tree because their whole body is rigid, all of their muscles. Or they could have clonic seizures where their body parts just shake and jerk uncontrollably. Then there's myoclonic seizures. If any of you have ever had your foot give that weird little twitch or jerk as you're falling asleep at night, that's kind of what a myoclonic seizure is like. They're just these large muscle jerks, there and gone. Those are one of those really quick, the seizures there and gone, and there's no first aid necessary for it. And then we have atonic seizures, which is the exact opposite of a tonic seizure. So here you're stiff as a board. Here, we also call atonic seizures drop seizures because it causes them to lose all muscle tone throughout their body all at once. And they fall, and they tend to fall with force. And people who are prone to these atonic or drop seizures will typically have to wear some sort of protective headgear. And then at the bottom, we have what we call the grand mal, the tonic-clonic seizures. And this is because this seizure presents with both the stiffening and the jerking and shaking, where the person cycles through it for the length of their seizure, whether that seizure is a minute or a minute and a half or 2 minutes or 3 minutes. And we really don't get concerned unless they get over 5 minutes, and then we start considering that an emergency situation. So here I've given you, and I forgot to tell you at the beginning, I did upload handouts. So you have a PDF file that you can download of all of these slides so that you can refer back to it if you want to. So this is what a typical tonic-clonic seizure will look like. There is often a cry or a scream or a groan at the beginning. They've lost consciousness because the seizure is flashing across both hemispheres of the brain all at once, almost instantaneously. It causes them to fall, and then they cycle through this rigidity and the rhythmic jerking and shaking. And during these seizures, excuse me, their breathing is shallow during the clonic phase, and it's actually, they're not breathing during the rigid phase. So that's why sometimes you might see their skin, particularly around their mouth, become dusky or actually blue if they're very fair-skinned. These seizures typically last 1 to 3 minutes, but don't ever guess at that because it feels a lot longer when you're the one that's trying to assist the person. And they're often followed by a period of confusion. The person typically complains of a headache, they're tired, they're sore. And I have met people who can't talk for a period of time after these seizures. They actually have difficulty with their speech. All right, so let's hope that this is going to work. Tell me if this video starts for you and you can see it. Are you seeing the video moving along?
Yep. Yes.
Good. Okay, so a couple of notes about that video. Let me change slides. If I can change slides. Oops, now it went back too far. I am just a hot mess today where the computer's concerned. That was your tonic-clonic seizure. These are actor portrayals, and these were made by an epilepsy group in Ottawa, Canada. And I just want to specify that when we get to the first aid, there's a couple of things that are different. Number one, In all my years, and my oldest daughter lives with a seizure disorder, I have never known anyone to catch her as nicely as that woman caught her boyfriend in that video. So please understand, it is somewhat staged. Some people could, notice them starting to fall and block their fall, but that's not typically my experience. More often I come in after the seizure has started. I hear the fall and then I come in. And then the second thing is they say to turn them on the side as the seizure subsides. Because there's an excess saliva produced during these seizures, we really don't like them to stay flat on their back if it can be avoided. And we never want to see them face down because they're somewhat paralyzed. They're incapable of turning themselves over during that seizure. And that could be one of the underlying causes of SUDEP, is that, they're having a seizure in their bed and they're laying face down and they're unable to flip themselves over and they suffocate. So think about turning the person on their side. If you're working with a client that's in a wheelchair, it's actually, we'll talk about that, it's perfectly appropriate to leave them in the wheelchair as long as their movements aren't strong enough to pull them and the chair over. Sometimes people have some really strong movements and they're jerking and shaking. Others, they just kind of look like these really fast tremors. Any questions about the tonic-clonic seizure? We will review first aid in a few minutes. I just want to show you all the videos first.
Nope.
Okay, thank you for the answer. So this next one, the sound is very, very soft, but you're going to see a high school student who's practicing for a play. And these seizures really are this brief. I hope you can all see it. Okay, that was it. They really are that brief. They're, as we can see on this slide that walks us through the typical progression or symptoms of an absence seizure, it's just like the old freeze tag or statue game. You flip a switch on them, there's a complete pause in activity with a blank stare. They're not aware of their surroundings. They don't understand or even hear anything said to them for those few seconds. And they're typically only 1 to 10 seconds. As a matter of fact, if you're seeing this staring symptom and you're getting over 15 seconds, start looking for other symptoms, because these seizures are often confused with focal or partial seizures with the loss of awareness, where they often start with a blank dazed stare. Some people will make a possible chewing motion with their mouth or blinking their eyelids, and I've seen some kids actually roll their eyes a little bit, but it's not universal. Some people, and I include my daughter in this, it's just a pause in activity. It's just as if somebody just told her freeze, and she stopped everything. So that's why these are often confused with daydreaming or not paying attention or an actual attention deficit disorder. Any questions about these?
No.
Okay, moving on. Now, so those are the two most common. As you saw from my list, I'm not talking at length. If you do have questions about the myoclonic or the atonic or the other seizures, you can always contact me by email or phone, and I'll be happy to have a conversation with you about your client in the group home that you're working at. So we're going to move over to the focal seizures, because believe it or not, more people diagnosed with epilepsy have these than the generalized seizures. 60% of the people with epilepsy, their primary seizure form is actually a focal or partial seizure. And I told you the seizure is only happening in one distinct area of the brain. So on this MRI, the neurologist has highlighted that this is the area of focus where the seizures are starting. All right. However, anything the brain can do can occur during these seizures. This is what makes them so tough to recognize as seizures and for people to handle, because they can look quite strange. Some people maintain gross motor control, so that means that they can have movements or even get up and walk around during these seizures, but not even be aware they're moving. Other people have just a very internal feeling where it's affecting one of their 5 senses. Other people will have a change in heart rate or breathing, or perhaps they'll break out in profuse sweating because it's the autonomic system of the brain that's being affected by the abnormal seizure activity. And some people, these are even harder to recognize. They'll have an actual psychological symptom where they look like they're having a panic or anxiety attack, or they're saying that they're hallucinating something, or that, you know, they're seeing or hearing stuff that nobody else hears. So let's look at some specific breakdown of how these seizures look. So the first one, people maintain their awareness. We used to call these simple partial seizures. Neurologists now, what you might see in the health record is that they're writing focal with awareness seizures. So the person is fully aware, but depending on what part of the brain is having the seizure activity, some people might present with a rhythmic movement because it's in that area of the brain. So you might see, now remember, you're only going to see it on one side of the body, because if the seizure is happening in the left side of the brain, you're going to see the movements on the right side of the body and vice versa. So they might say that there's arm movement, or a side of their face is twitching or drooping. Oftentimes these are mistaken for strokes if they happen in the face, or perhaps their leg is doing this odd movement that they can't control. Now they typically are brief. They're typically less than 1 or 2 minutes. But other people might say, oh, I have an aura, I have a warning. That aura or warning is actually the start of one of these focal aware seizures. And typically those people will say, you know, whenever I get this funny tingling sensation, or, you know, I feel a little nauseous, sometimes that warns me that I'm going to have one of my bigger seizures or one of my seizures, they'll say. So people can have a funny smell, a funny taste in their mouth. They can hear sounds that nobody else hears, or there can be an actual visual distortion of their visual field because it's affecting, you know, one of the senses. And then I alluded to the psychic symptoms where it's really tough because they're having these feelings that they may or may not be able to explain to you what they're feeling, like a sense of deja vu where, oh, you know, I feel like I've done this before, you know. I call it like if you've ever seen the old movie Groundhog Day with Bill Murray, it's like that. Or they have jamais vu where they should know where they are, but they don't. It's like completely new to them. So these seizures, if recognized, there's no first aid necessary for them, but you certainly want to document them so that, again, the family members can make the neurologist aware that it's occurred. Now, on the other hand, seizures with a loss of awareness do affect they're not aware of their surroundings. They're unable to respond to instructions that are given. And they're often mishandled because people do not recognize them as seizures. So this mom posted her son. I don't know if this is going to show. Are you seeing YouTube? Did it flip screens for you?
Mm-hmm.
Oh, it did. So you can see the little boy?
Yeah.
Yep.
Okay. So you see his tongue and his mouth?
Yep.
Oh, poor kid. So, okay. So a couple of things. First of all, we didn't see this seizure. Whoops, where's my slides? Here we go. So we didn't see his seizure from the beginning. Mom, some unknown period of time, Mom turned on the camera and was videotaping it. But a couple of things that I want you to notice was that blank stare. These often start with a blank dazed stare, and then you'll see other movements, sometimes automatic, what the doctors call automatisms, where he wasn't doing this, but, or at least we don't know that he was, but not right now. They could pick at their clothing or wring their hands. He was drooling and his mouth was twitching on only one side. Other people might actually smack their lips or lick their lips or look like they're chewing, but they're not eating. Sometimes they'll make sounds. I didn't really hear him make much in the way of sounds, but I've heard other people mumble, but it's not speech that you can understand. I've heard other people groan during these seizures. Some other people actually have these emotional outbursts because the seizure is happening in an area that controls our emotional behavior. So as you can imagine, if a person has one of these in public, very few people will recognize it as a seizure, and they're going to look at the person and say, oh my God, is that person drunk or on drugs, or are they mentally ill or something like that? And for these seizures, Dad is holding him, and he said he felt the relaxing. So there must have been some stiffening in the boy. And the mom said, it came on suddenly, you were on the couch. And obviously by the time we see him, he's not on the couch anymore. He's sitting on the floor and Dad's kind of hugging him. They know their kid. But when you're working with a client, if you were to grab them or force them to sit down or lay down, they might push you away and struggle with you. So that's why we say don't restrain them in any way. Just kind of shepherd them and keep them safe. And sometimes if they have the kind of seizure where they walk around the room, which they can during these seizures, it's as simple as shutting the door and then just letting them wander around throughout the seizure until it's over. So in this next slide, this is another one of the Ottawa videos. It is an actor portrayal, but it's a very, very good one. And I want you to pay attention to the sudden onset of the seizure and the small movements that you see, all right? Let me see the time. Okay. So did you notice how abruptly it came on? He's talking at a meeting, giving his presentation, and boom, it comes. Is there anything else that you noticed that jumped out at you? No? All right. Well, maybe when we review Seizure First Aid, it'll make some sense. So honestly, the best thing you can do is remain calm and understand that seizures usually end on their own. In the case of absence, in seconds, and in the case of focal with loss of awareness or generalized tonic clonic, within a few minutes, right? So you just want to think about giving care and comfort. You want to create a safe space. You want to move any objects that their arms or legs might hit or that they might bump into out of their way. You notice she asked somebody to push the chair in so he wouldn't bump into it as he was wandering around the room, the meeting room. In the case of a tonic-clonic seizure where they've fallen and lost consciousness, you want to roll them on their side. Again, it helps with their breathing, but it also prevents them from aspirating or taking some of that excess saliva into their lungs and setting them up, 2, 3, 4 days later, developing pneumonia, which we hate to see. And when they're having that tonic-clonic seizure and you've put them on their side, find something soft to put under their head, not on their face, just under their skull. And if there's nothing close at hand, I know I've been with my daughter where I just put my hand under her head to keep it from hitting the floor. When they have the seizure where they're wandering, you notice the coworker, she just kind of stayed with him. Now, she had her arms very loosely on his shoulders. I don't even typically touch them. I just stay close by so that I can keep them safe. My only exception is if I was concerned, we were outside, and I was concerned that they were going to step out into the street, that would be my exception. I would pull them back because that's, I need to keep them from doing that. Also, if you're inside and they're heading for a flight of stairs, I would definitely steer them away from that. But try to make your movements more of a shepherding movement rather than a forcing and grabbing them type of movement, okay? You want to time the seizure because that's what's important. We know from working with millions and millions of people living with epilepsy that when their seizures begin and end naturally on their own, the outcome is better, all right? It's just part of their neurological condition. But we want to time it and we want to report to the doctor, hey, today on Thursday, September 12th, Jack had a tonic-clonic seizure that lasted, 70 seconds, and that's because you actually timed the stiffening and shaking, not to the time that he's awake and back to normal, because there's always that recovery period afterwards. If you wanted to time how long the recovery period is, you would, either use your watch or your cell phone or, honestly, I just count in my head, 1, 1,000, 2, 1,000, 3, 1,000, and so on. And that counting just kind of gives me something to do so that I remain focused and calm. And then I can tell how much time elapsed by the number I got to. So the last time I did this, I had, with my daughter, she was tonic and clonic, meaning she was rigid and jerking and shaking for 45 seconds because I counted to 45. And then she just went tonic, just stiffening for another 15 seconds. So I was able to tell her, hey, your seizure only lasted a minute because I counted to 60, but this is what it looked like. For 45 seconds, you were tonic and clonic, and then for 15 seconds, you were just tonic. Other people, I've had to count up to 90 because their tonic and clonic seizure lasted that long. Same with the focal seizure. You want to note how much time's elapsing because those can last 1, 2, or 3 minutes. And then when the seizure ends, because they're confused and somewhat sleepy and have some other unpleasant side effects, you really want to stay with them until you're sure they know where they are and they're back to what's baseline for them. Now, I understand that's going to be very different because you're working with a population that has cognitive, intellectual disabilities. So it's going to be different for each person. But don't be alarmed. Their typical tonic-clonic seizure might be 3 or 4 minutes, but because that's typical for them, it's okay to just ride it out and just make sure they don't injure themselves. And again, I want to stress, we don't put anything in their mouth. We just turn them on their side, and we don't restrain the person no matter what type of seizure. When do we consider seizures a medical emergency? Well, when that seizure is lasting longer than 5 minutes, or if they injured themselves in the fall, then yeah, they have to go to the ER because that has to be treated. When the seizure lasts more than 5 minutes, some of your residents are going to have an order for Jesus, I have to stop touching that. They have an order for a rescue medication, so we'll have to go through the protocols for that. But you're not giving it for every seizure you're seeing. You're only giving it for the seizures that the doctor has written the instructions and said, give if the seizure lasts longer than 5 minutes. Occasionally, you'll have someone whose protocol says, give rescue medication at 3 minutes, and that's just because the doctor has seen them have prolonged seizures and doesn't see the point in letting them continue to seize. So you always want to look at what the neurologist wrote in their seizure action plan for that person. Certainly if the person was not diagnosed and that as far as you know, they've never had a seizure before, yeah, they're going to the hospital because there's lots of reasons why that seizure could have happened. And epilepsy may or may not be one of those reasons. Certainly if you see that they're not returning to normal breathing patterns, at the end of a tonic-clonic seizure, oftentimes I will see my daughter sleeping and her breathing is ragged, like she's snoring, but it's regular, so I know she's breathing. But you want to certainly pay attention that that returns. And certainly if somebody has a seizure before they've recovered from the previous one, that's a medical emergency, that we might be seeing the start of a cluster of seizures, and we want to put a stop to that. So that's another reason why a rescue medication might be given and 911 might be called. If someone that you know if it's a woman who's pregnant and she has a seizure, or if it's someone you know and they have diabetes or a heart condition, those are always medical emergencies because it's very, very dangerous. So what you're going to do is call 911 right away and then go and do the first aid protocol where I still want you to time it because that's really important information to let the EMT know, hey, listen, they were seizing for 3 minutes, and now they're not, but, we're really concerned because this person has diabetes, so you're not waiting. For the person with epilepsy, it's reasonable to ride the seizure out and wait those up to 5 minutes. But for people who have a heart condition or diabetes, we're not going to wait. We're going to call 911 right away, and then we're going to still provide the care and comfort. And then certainly we're concerned if anything happens in a swimming pool, a lake, the ocean, or even the bathtub. We highly, highly recommend that people with seizure disorders do not take baths, that they take showers, and that there's care always taken to make sure that the drain is working properly. Because if they fall in there, all they need is their nose and mouth to be covered with water to drown. All right. Now, if you ever have a client, because we're getting to the end of the hour, I'm not going to spend some time on these treatments, but if you do get into a residence where you find out that they're being treated with something called the ketogenic diet, just get back in touch with me and I'll explain to you what's going on. Just know that they must follow the diet exactly. That's the most important piece of information. Some of your clients might have a device implanted, and the more common one is the vagus nerve stimulator, where what you're seeing here implanted under the skin on the chest is on the left side is a generator, and then the leads come up the neck right past the voice box, and they're threaded around the vagus nerve. And this device is on 24/7. So for example, it might be sending a 30-second pulse every 5 minutes round the clock on its own. In addition, people are given a magnet, either a caregiver or if the person themselves has the warning where they can feel their seizure starting and they haven't lost awareness yet, they can wave the magnet. And when I say wave it, I don't mean like this back and forth movement. It's really, think of sternum to armpit or armpit to sternum, one way or the other. All you have to do is pass that magnet once over the generator to turn it on to send an extra pulse up the vagus nerve, with the theory is that we're hoping that it'll interrupt that seizure. Okay. Typically, this is not a cure. It's not in place of their medication. They're usually still on medication in addition to having this device. The rescue medication that are often used here in the States is a Diazepam Rectal Gel. This is what the applicator looks like. It's a syringe. This is not an EpiPen. This is not something that you're punching into them. It's an insertion tool. And I included the instructions in case you are asked to provide rescue medication. So they come in pre-measured doses. And the thing you want to look is, number one, that your resident or your client's name is on the prescription. On the box, it should have that prescription label. When you open it up, you should see this green ready band, which means that the pharmacist set the dose. And if you look in the teeny little window on the applicator, you'll see the dose there. All right. It also comes with its own lubricant. And then I would always, I'm sure you have gloves on hand in the group homes for other, bathing and other things you have to do. Hopefully non-latex, because we're running into more and more latex allergies. So you glove up, the person is getting to be, the tonic clonic seizure has been going on for 4 minutes. Have someone get this for you, or you go get this very quickly. Open up the box, take out the syringe, confirm, that it's ready. Now, when you take off this cap, see this outline cap? Inside there's a seal pin. Make sure that you pull it off straight. Don't bend it in either way, because that sealing pin, you have to see it in the cap, because if you don't, it means it broke off in the applicator. All right. Stick the applicator, rip open the little packet of lubricant that comes with each of these. Dip the tip in it liberally. Turn the person on one side. Now, normally during first aid, I like to be behind the person with my hand under their head. But if I have to give diastat, I'm going to move so that the person is facing me. And yes, that does mean that you're probably going to be hit by their arms and leg movement. But it's easier to administer the diastat if you can pull them towards you. You don't have to take their clothes off. All you have to do is pull down the pants until you expose the buttocks. If you can, take the top leg and kind of bend it forward so that it kind of helps to spread the cheeks, expose the buttocks. And then you gently insert the syringe into the rectum. And you push the plunger in and you do a slow count of 1, 2, 3 as you're pressing the plunger down. And then you hold it in there, hold the syringe in there and count to 3 again. 1, 2, 3. And then you slowly withdraw the syringe and squeeze the cheeks closed with another slow count of 1, 2, 3. And then you just dispose of the medication. And then you follow their seizure action plan. That's what SAP stands for, seizure action plan, for follow-up and after seizure. Post-sictal means after seizure. So if there's ever any questions about this, I'm happy to have a conversation one-on-one with you if you are asked to help out, particularly if you're there overnight and someone has night seizures. Any questions about that?
No.
No? Okay. Moving on. So this is a video. I'm not going to show it to you right now, but it's a video of actually demonstrating it on a mannequin. We are very, very happy that there's an intranasal rescue medication, which, obviously it's going to be much more desirable to not have to use a suppository, that being able to spray something up each nostril would be much easier. So the drug is called midazolam, and it was approved in the United States in May of 2019, but the manufacturer was not ready. So we haven't seen the product actually come on the market in a pre-measured dose type. But what doctors are ordering now and what we see coming from compound pharmacies are you get a vial and you get this syringe and you have to draw up the dose. So as you can see, the milliliters are listed here. And then you actually have to screw on this atomizer onto the top of the syringe. And then you have to spray it up each nostril. So the nose can only absorb so much medication, so you typically have to split it and put half the dose up one nostril and half the dose up the other. So some of your residents may, because they're adults, you know, the doctors say, hey, you know, let's give them their dignity. Diastat's not ideal. Don't get me wrong, it works. We use Diastat because it stops the seizures, but they may prescribe this. So again, reach out to me if you have any questions about this. You just want to be aware of some triggers, and I am going to wrap it up. I see it's 3:03, and I'm sure you guys have to go. But you want to be aware of things. Number one, your resident has to take the medication that they're prescribed, their daily treatment medication as it's prescribed. Some people might take an extended release dose where they only need it once a day. Others might have a twice-a-day dosing where the levels last for 12 hours. So they have to take 2 doses per day. And some people with really severe forms of seizures or who are very, very sensitive to the side effects, the doctors might break it up into smaller dosages multiple times a day. But missing medication is the #1 reason people have breakthrough seizures. You may have heard that people with epilepsy are photosensitive. Actually, that only occurs in about 3% of people diagnosed with epilepsy, but everybody's heard of it. But if you do see in their record that they're somewhat photosensitive, you do want to protect them, not just from fluorescent lighting that flickers when it's dying out. When those fluorescent light tubes are dying out, they do that annoying flicker. But also you want to be aware of if they're watching TV and something, particularly animation does this a lot, where the images are flashing very, very quickly, because it's actually that strobe effect, the patterning of the light that can potentially trigger a seizure to occur. So that's what we want to be aware of. People with epilepsy need their sleep. We actually sleep deprive for EEG when we want to capture a seizure to see what's going on. So their sleep is very, very important. You know, if you're working with adult women, you want to be aware of their menstrual cycles because there are hormonal changes, and some women's seizures are very sensitive to those high estrogen levels. So there might be a certain point in their cycle that they're more prone, or it might be easier for them to have seizures. And certainly if they're getting sick, pretty notorious, pretty common that people with epilepsy say, I have to be extra careful when I've got a cold or a strep throat or bronchitis because it lowers their seizure threshold. And then as we move into fall, which is a gorgeous time of year around here, I'm so excited, much as I'm sad to see the summer go, just keep in mind that if we do get some of those unusually warm days, make sure they're not overheating, make sure they're staying well hydrated because that can affect them as well. Oh, here's that midazolam spray again. I had them out of order, I'm sorry. And then I leave you with this link. So if any of these terms, or if you read something in your resident's chart that you don't understand, this link will get you to a whole glossary of definitions of words associated with the condition epilepsy. Do you have any questions at this point?
No.
No? Okay. Well, I want to thank the 3 of you for spending this time with me this afternoon. I am going to email Jenny Rain's certificates of completion for you. And as soon as I close down this survey, would you please wait a few seconds and not sign off? There's a survey that's going to come out. If you do have to leave right away, I do have it set up so it'll be emailed to you at the address you registered with. And if you could just please take a few minutes to let me know, was it enough information? Was it too much information? You know, just answer the questions, because that helps me improve this training. And Jenny has me do this every year when she has a new group of people. I want to wish you a successful year, and don't hesitate to reach out to us, okay? And I also include, I think I have my contact information in here as well. Yeah, there it is. All right, and those are in the handouts. So thank you for your time this afternoon. And if there aren't any questions, I'm going to end the session right now. Thank you so much.
Thank you.
Bye-bye.